So first and foremost, the management guideline is to take the full history and examination of a patient. Now, they may provide important clues to the etiology of the renal failure. Now, for example, a history of frequent urinary tract infections in childhood may suggest a diagnosis of reflux neuropathy, whereas a family history may suggest polycystic kidney disease. So you can see how important history taking is. Now, hematuria found at previous medical examinations might point towards chronic glomerulonephritis. Now, it is important to establish that the renal failure is truly chronic, like I told you earlier, so that we have to ensure that there is no acute and reversible cause of renal failure. So the previous estimations of renal function are of the greatest help in determining this. Furthermore, the absence of anemia usually suggests that the renal failure is acute rather than chronic, whilst small kidneys are usually found in the chronic disease. This is why it is important that we investigate the patients that are suspected of chronic kidney disease and include the renal tract ultrasonography to exclude obstruction and document the renal size. Now, if the cause is unclear and the kidneys are of normal size, then a renal biopsy is usually undertaken. Furthermore, other than this, tests are usually conducted to exclude melanoma and autoimmune diseases like systemic lupus erythematosus and vasculitis. Then we also perform urinalysis to detect proteinuria, hematuria, and urinary infections. Moving on, the severity of the renal failure is determined from creatinine, urea, and creatinine clearance levels. So after all these examinations, once significant renal dysfunction develops, there is usually an inexorable deterioration in the renal function over several years. This is possibly caused by hyperfiltration in the remaining glomeruli. Now, apart from the treatments that are directed against the specific cause of the renal failure that we talked about earlier, now the main therapy reducing the speed of deterioration of the kidney is aggressive blood pressure control. Now, you must remember an important term that is usually used, which is end-stage renal failure, or ESRF. This is a term used when patients would not survive without renal replacement therapy, which usually includes hemodialysis, peritoneal dialysis, or renal transplantation. Patients are prepared for renal transplant therapy by creating dialysis access before the renal failure progresses to cause uremic symptoms. So keep this in mind. Keeping this in mind, before dialysis, calcium balance is corrected using 1-alpha-hydroxycholecalciferol, and phosphate balance is corrected by using phosphate binders. Anemia is improved by erythropoietin administration, and acidosis is ameliorated with sodium bicarbonate. Hypertension is treated, and the sodium and water retention are controlled with diuretics. Now, usually the indications for dialysis that you have to keep in mind are, first up, uremic symptoms with the usual indications. Often when creatinine is more than 500 micromolar per liter. There may also be life-threatening complications like hyperkalemia, acidosis, fluid overload, uremic pericarditis, or even encephalopathy. Now, in the case of hemodialysis, the vascular access is achieved forming an arteriovenous fistula, which needs 8 weeks to mature before use, or by using double lumen, jugular subclavian, or femoral lines. The diffusion of solutes and water occurs across a semi-permeable membrane, which separates blood and dialysate flow in the opposite directions. Now, the major difficulties with hemodialysis are cardiovascular instability from concurrent cardiovascular disease and drugs that are used for this treatment, as well as major fluid shifts that occur during dialysis. Now, the difficulties in adhering to the dietary and fluid intake restrictions and difficulties with vascular access are also the major difficulties that arise with hemodialysis. Remember that dialysis membranes can activate the clotting cascade. So, heparin is used to prevent this. Most membranes do not allow the removal of beta 2 microglobulin, which accumulates, causing carpal tunnel syndrome and arthropathy in some patients. Now, the over rapid removal of toxic metabolites in the case of dialysis causes a profound illness, which is known as dialysis disequilibrium, particularly happening during the first dialysis treatments. Now, this can be prevented by frequent small dialysis schedules. In continuous ambulatory peritoneal dialysis, patients instill several liters of isotonic or hypertonic glucose solution 4 times a day into the peritoneal cavity via a permanent catheter, or connect to a machine which does this at night, or also known as automated peritoneal dialysis. The peritoneal lining acts as the dialysis membrane. And after several hours, the fluid containing the solutes and waste products is drained out. And excess body fluid is removed by using hypertonic solutions. And so, after several hours, the fluid containing the solutes and the waste products is then drained out. The excess body fluid is removed by using hypertonic solutions. Now, the most common complication of this treatment is the infection of the peritoneal fluid, which is the peritoneal dialysis peritonitis. This requires treatment with intraperitoneal or intravenous antibiotics. So that is all about chronic kidney disease. I hope you might be able to learn something beneficial from this lecture. And previously, we also covered acute kidney disease in a different lecture, so do check that out as well. And keep watching sqadia.com to learn something new every single day.